Hi everyone, welcome to Anesthesia Snapshots. Today, we're going to cover aortic stenosis and the key anesthesia considerations that every provider needs to keep in mind. Let's dive right in. Aortic stenosis, or AS, is a condition where the aortic valve narrows, making it hard for blood to flow from the left ventricle into the aorta. Over time, this increases pressure in the left ventricle and can cause it to thicken, a process called left ventricular hypertrophy. Severe AS is often defined by a valve area less than 1 square centimeter, a mean gradient greater than 40 millimeters of mercury, or an aortic jet velocity over 4 meters per second. Symptoms include syncope, angina, and dyspnea, easy to remember as SAD. If left untreated, severe AS has a poor prognosis, so understanding how to manage these patients safely during anesthesia is critical. Let's talk about the main goals of anesthesia management in patients with aortic stenosis. Our top priority is to maintain stable hemodynamics. Because of their fixed stroke volume, patients with severe AS can't adapt to big changes in blood pressure or heart rate. First, avoid hypotension. Sudden drops in blood pressure reduce coronary perfusion and can lead to myocardial ischemia. That's why we often use vasopressors like phenylephrine, which increases systemic vascular resistance without affecting the heart rate. Second, avoid both tachycardia and bradycardia. A high heart rate shortens diastolic time, which reduces coronary perfusion. But bradycardia can lead to low cardiac output since these patients rely on a fixed stroke volume. So, a steady heart rate of 60 to 80 beats per minute is ideal. Next, maintain preload and afterload. Patients with aortic stenosis rely on a high preload for adequate ventricular filling, so fluids may need to be given cautiously. An afterload should also be kept high to ensure coronary perfusion. Sudden drops in afterload can lead to dangerous ischemia. Now let's look at anesthetic technique and monitoring. In severe aortic stenosis, we generally avoid regional anesthesia, like spinal or epidural, because of the risk of hypotension from vasodilation. Instead, general anesthesia is preferred, but induction agents need to be chosen carefully. Drugs that cause vasodilation, like high doses of propofol, should be avoided, and agents like etomidate, which maintains hemodynamic stability, are often better choices. In terms of monitoring, invasive monitoring is a must. An arterial line allows us to closely monitor blood pressure, and central venous pressure, or CVP monitoring, can help manage preload. For high-risk cases, transesophageal echocardiography, or TEE, is invaluable because it lets us monitor cardiac function in real time. Finally, let's talk about postoperative care. Patients with severe aortic stenosis are often at risk for hemodynamic instability after surgery, so they may need ICU monitoring. Close postoperative care ensures that any issues with blood pressure, heart rate, or fluid balance are addressed promptly. To summarize, the anesthesia plan for aortic stenosis centers on stable hemodynamics, maintaining preload and afterload, avoiding rapid heart rate changes, and closely monitoring the patient. With the right precautions, we can safely guide patients with aortic stenosis through surgery. Thanks for watching. If you found this video helpful, don't forget to like and subscribe to Anesthesia Snapshots for more quick anesthesia guides. See you next time.